So that was excellent, and I will tell you about the neoadjuvant therapy. Actually, Dr. Skitsky and Dr. Switzer kind of summarized, what we do in there. Stay tuned. There will be a definitive trial presented at ASCO this year called Nadina, which is basically taking that approach and making it in a more patients. The data will be presented on June 3rd, which is Sunday, which kind of tells me it's going to be a plenary session, although that has not been officially announced yet. But that's what it will be. Actually, June 2nd, not 3rd, June 2nd. So I will tell you about the metastatic melanoma. So when all this fails, the surgery fails to cure the patient, the neoadjuvant or adjuvant therapy fails to cure the patient, patients develop disease in other organs, metastatic, unresectable, and these are my disclosures. And then what we do. So you'll see kind of these three different approaches. I'll be talking about the bottom one, which is the systemic therapy for advanced melanoma. So traditionally, the therapies were few. In the 80s, we used the carbazine, that was the chemotherapy. That was actually approved on one trial with like 70 patients, where 10% of them had a shrinkage more than 30%, and that lasted less than 4 months, but there was nothing else, so they became a standard. Then Dr. Rosenberg, actually, who is a pioneer of immunotherapy at NCI, pioneered the approach with interleukin-2, high-dose interleukin-2, and he also at that time pioneered a treatment with what he called LEC cells, lymphocyte-activated cells, killer cells, or tumor-infiltrating lymphocyte cells. And I'll come back to it at the end, because what was once old, is now new. And you may ask, why was the interleukin-2 approved, in the 80s, but not the cells? And the reason was that when FDA looked at his data, they kind of understood about the, interleukin-2 feeds, activates the immune cells and helps the patient, but they couldn't really get their head around, the mixtures of cells come in and what they do and, how you select them. So they said, do more work on the cells. And we actually get approval just for what was really to support, the cells. And you can see the outcomes were pretty dismal. In the 36 months after your diagnosis, almost everybody died. And when you look at the typical 6 months, that already 50, 60% of patients died. So the median kind of patient, the middle one, not too good, not too bad, was alive between 6 and 10 months. And that was state of the art until these two mechanisms came, and you heard about them. One is the immune mechanism on the left, and one is the kind of a tailored, targeted mechanism taking advantage of the vulnerability of these tumors, which is the BRAF mutation. And so that's what happened, and this is like how it went. And I was lucky because I was part of all of that, started in 2005 when I became faculty at Vanderbilt. And even when I was a fellow, we had trials with ipilimumab, that's the CTLA-4 antibody. That's what Dr. Ellison got the Nobel Prize for. He's an accomplished harmonica player. That documentary movie Dr. Switzer alluded to, I encourage you to watch it. He actually played on stage with Willie Nelson, and he plays in the group, which is our traditional Society of Immunotherapy in Oncology group, which was a bunch of nerds. For many years, nobody cared. And he gets drunk and plays harmonica. He's a really fun person. I love him. And there are other accomplished people who used to be young and inconsequential. And now when you go to these performances, which we have at all different meetings, like American Association of Cancer Research, you always hear performance by checkpoints. And everybody who is on that stage is like cancer center director, member of National Academy of Sciences, and they do a lot of good music. So that's a lot of fun. And you can see vemurafenib there. That was the first BRAF inhibitor. Then we figured out you are better off giving it, in combination with MEK inhibitor. It's all on that pathway. that's trametinib, and it's like one by one. You see pembrolizumab and nivolumab, close by. These are the other checkpoints, the PD-1, the programmed cell death ones. Then you see the combination between ipilimumab and nivolumab. Put them together, they are better. I'll show you data. Then you see something called TVAC, which was really kind of a work of heart. Nobody believed in it. That's actually oncolytic virus. You take a herpes virus, you modify it so it cannot infect people, so it's like harmless, and then you put some like some molecules to stimulate immune system, and when you inject it into tumors, you may make them disappear, some of them, and it's really good for patients who want to avoid some of these toxicities Dr. Switzer talked about, and at the same time, they want to, they have some tumors and the surgery would be too extensive. Let's say if you have 10 tumors on your arm, having a surgery would be pretty debilitating. On the other hand, they are not doing much to you. So you worry about all these itises because you can die from them. And so you say, well, why don't we just inject them and see what happens? And sometimes it happens good things and it's all good. And if not, you can always go to the stronger treatment, because then you need it, but you actually may potentially avoid those side effects. Then you have additional combinations of targeted therapies. And then as you can see, we even have a one triplet combination. That's the atezolizumab, vemurafenib, and cobimetinib. That's kind of like a dead child born because it's pretty marginal. And actually, although they met the primary endpoint, when the investigators looked at responses, but they didn't actually meet the same criteria when like a radiologist looked at it. So you tell me, when an investigator looks at something, they tend to be more optimistic. When a person who has like no vested interest looks at it, if the effect disappears, we really don't use it really at all. Then there is the nivolumab relatlimab. I'll talk about it. That's a new kid on the block. It's a different checkpoint inhibitor. Relatlimab, hits another pathway. And then tebentafusp, I put it there because it's the first and only drug for eye melanoma. And I have been involved with it since 2015. And it is really a new novel, mechanism. And but it's not used in skin-based melanoma yet. Maybe never will, but it opens some door to other drug development. And last but not least, as of February of this year, lifileucel, that's the cell therapy. That's actually the tumor-infiltrated lymphocytes, which I told you were actually studied by Dr. Rosenberg in the 80s. So that's really what it is. And so what do? We have a patient, and let's say the patient has a metastatic melanoma, and the metastatic melanoma you test, with pathologists, and they have the BRAF mutation. So in the old days, we didn't know what to do because some people gave the targeted therapy, and that was good. Some people gave the immunotherapy, and that was good. And then people, of course, had a lot of discussion which one is better. So instead of discussing, it's better to do trial. So these are two trials. The first one with the 3 arms is European, Secombit, and the other one is American called DreamSeq. Took us a long time to figure out a catchy name. And what it is, you take those patients, you randomize them, and half of them, will get the targeted therapy first, the other one immunotherapy, and then if they have progression, you kind of flip it, and to the other treatment, and you see which one sequence is winner. And Italians, they did a third arm where they actually kind of gave the targeted therapy first, but only for 2 months, and then again they gave the immunotherapy and went on. And what happened, this is actually the DreamSeq data. What you can see, the black curve is the winner, and that's the curve where you give the immunotherapy first. And the red, curve is the loser. That's where you give the targeted therapy first. That's why we rarely use the targeted therapy first. But you can see at the left, right here, that the red arm was a little bit better at the beginning. But as you can see, all these patients are doing poorly because 100% are alive here, and only about 60% are alive here. And when you look down, that's like 8 months. So these are the patients who have the primary refractory melanoma, like a bad one, and they kind of die on you pretty quickly, and it's about 3 out of 10. That's the last trial I would like to do in my career, to figure out how to help this group. And of course, you can see they do a little better with the targeted agent, but no cigar, because the difference is what, 2 months, 3 months, and then they die again. So these are the patients of unmet need. We hope to have something for them in next 5 to 10 years, maybe something radioactive, like radioactive antibody, maybe something similar. But that gives you an idea. So if somebody asks, I have a BRAF mutant melanoma, no matter what the internet say, or whatever people say, you tell them immunotherapy is the winner. That's what you should be having first, and then you can have the other one second. And that's the overall survival. Again, you can see that top group, dying pretty quickly. Again, 10 months, 20%, are not here. That group seemed to be doing a little better with the targeted therapy, but you come to this joint and that's it. And long term, the winner again is if you give immunotherapy first. And you can see there is actually a big difference. So giving targeted therapy first, actually, I would argue is almost malpractice unless you have a good reason for it. Because if you start with targeted therapy, this is how people end it. And remember, they were allowed to get immunotherapy later, but it didn't make up for that initial deficit. So immunotherapy first. Combination immunotherapy. In this case, it's ipi-nivo. Better outcomes. Not every patient, but again, that group where the target therapy is better, it's better by just a couple months. And the nice thing about the targeted therapy, I will just point to you this. What it means is whether you give it actually upfront or whether you give it after immunotherapy, you still have about 43-48% of patients responding. So when people say, yeah, but I would like to get a targeted therapy, it may not work later. It actually works later also, so you can safely defer it to the second line. And so that's really what it says. So for a stage 4 melanoma, regardless of the BRAF mutation, one should start with a combination immunotherapy. And if a patient progresses, the targeted agent can be left for later. But what about that new combination? That's the combination not with nivolumab, ipilimumab, but it's the nivolumab, relatlimab. So this is the plenary session of Relativity 047 trial. And as you can see, they were looking at progression-free survival. These are patients, again, 100%, not progressing here with melanoma stage 4. They have BRAF mutation or not, it's a mixture. And again, you can see that some people progress very quickly. That's really the same group. We still need to do something for them. But then the curves separate, and the blue one is the combination of the relatlimab, nivolumab. So it's better than nivolumab alone. That's why when you come to my office, we actually try to give you a combination of immunotherapy. And what is actually nice about it, that all the different groups, were helped. And when you look at the BRAF mutation, whether you had it or you didn't, you benefited the same. The dotted line here means that it's a wash. If you see this little ball on the left side, the combination is the winner. And the blue lines, what they tell you, if they cross the dotted line, then you kind of cannot tell. But if they are firmly here, then it's statistically significant. Then it's like a done deal. You cannot argue with that. So you can see that BRAF mutation, pretty aligned. So whether you have BRAF or not, this is the winner. And these two, just a little for anybody who is interested in detail, you see that PD-L1 expression on a tumor. And if you actually had it, it looked like you can get either combination or the single agent. And if you didn't have it, then of course the combination was the winner. But because this was not how the trial was originally written, in the US, we approved the combination regardless of PD-L1 marker expression. In Europe, where they actually try to be most cost effective, they actually gave the approval in a PD-L1 expression low patients only. Whether it's right or wrong, I don't know, but that's what they did. And the key is, we now have a second combination, and there is a survival curve, and you can again see improvement. But when you look at it, the improvement is there, but is it 100%? No, it's like, 6, 7, 8%. It's significant, but at the same time, we need to do better. So we still need new drugs, to actually help the rest of those patients. But as Dr. Switzer said, and as I said, remember that survival in the old days was here, and we are here. So, we went a long way. And the melanoma was voted, or not voted, it was assessed as the most improved, solid tumor survival by American Cancer Society. So the relatlimab approved in 2022. And here you have it summarized. Response rate means mostly shrinkage, 30% or more. So if you have a, single agent Keytruda, that's dead. Nivo, it's dead. And then you have the Nivorella and then Ipi-Nivo. So Ipi-Nivo seems to have the best shrinkage there. When you look at 2 years progression-free survival, still Nivo, Ipi seem to be the best. But when you look at the survival, they seem to be pretty comparable. And in terms of the toxicity, 60% will have pretty bad toxicity with this combination, but only 21 here. So, somebody who is older, fragile, has a emphysema, heart disease, kidney disease, whatever other disease, that combination actually plays a big role because it can be given more safely, and you can always, again, save the more big gun, safer, for later. But I will show you there are some situations where you don't. That's just saying that the BRAF mutation doesn't matter in this combination. It's the same good for both. And this is just to try and to, kind of read tea leaves, if it's better to use this combination or that combination in general. And basically what it is, it's hard to compare, but, no idea. They look very similar in terms of survival. We'll see the updates, and obviously everybody and their mother would like to have some biomarkers. What it means is to have some test which tells you which one is better for individual patients. We are working on that with a company called OncoHost, and maybe, just maybe, we will have it, but not yet. And there you have it in summary, that the frontline immune checkpoint inhibition is proven superior to BRAF-targeted therapy, especially Ipi-Nivo. We didn't test Nivorella in that same situation. And there are some small populations which may benefit from targeted therapy, but it's pretty sure they really need new drugs. And the jury is out, whether the nivolumab, ipilimumab, or nivo-relatlimab is better. They may end up being similar, but it doesn't tell you if there are some individual patients who may benefit more from one or the other. And the toxicity is different. The Nivorella is less toxic. So if you say, doctor, give me something which will be less likely to make me sick, give them Nivorella. It's a discussion we have with patients, some of you know. And that's what we do. But some of the patients don't have a choice. If patients come with brain metastases, I actually co-wrote that trial, this one, and that was the trial which we published in New England Journal of Medicine, Checkmate 204. We gave patients the combination of the nivolumab, ipilimumab, and the that was the arm of 101 patients who had a small brain metastases. They didn't have seizures, didn't have much headache. And look at that, 61%, had a progression-free survival. 54% had a shrinkage in the brain. If you remember the data I just showed you, that's the patients without actually brain metastases at 65 and 58. And now you are looking at somebody with brain metastases here, and it's actually 61 and 54. Basically, Ipi-Nivo works the same in the brain as it works in the body, which is like amazing breakthrough. And but only if you don't have trouble from these brain metastases. These are the patients who had trouble, seizures, headaches, steroids, and look at that. These numbers drop. So this is another area of unmet need. If you come and you have big tumors in the brain, headache, and you are wobbly and having seizures, then that's not good news. And this is very similar trial from the Australian group. And this is the targeted therapy. It also works in the brain. And you may ask, how do we use this? Well, if you come and you belong to that B arm and you are wobbly and you have pain and you have a lot of, steroids on board where the immunotherapy would not work, I give you the pills, have you shrink the tumors in the brain, and then I give you the immunotherapy when you become, kind of stable, no steroids, no headache, no seizures, no nothing, and hope for the best, which sometimes happens and sometimes it doesn't. So patient with advanced melanoma, progresses, and now what do you do? This is a table of all different things you can do after progression on a first-line therapy, because remember, not everybody is lucky to be that 50%, 60% survivor, and you have other things. So for example, if you get ipi-nivo initially, or PD-1 in general, you can actually salvage some of them with, again, that new combination, because if somebody is on the ipilimumab, nivolumab, they all had a PD-1, 57% had a ipi. So, pretty standard population, 12% actually had a response rate, and median, the kind of a duration of the response was not reached, which means that you can have meaningful salvage, but only for about, 5 to, 10%. So, we need something, after the progression on Frontline. This is more historical because we don't treat patients like that anymore. But this one I will put to your attention, and that's the cells, that's the lifileucel. That's the latest approval. You can see heavily pretreated patient, and the response rate here is 49%. What this means is that's the pills after progression on immunotherapy. We know that they will work, but they only work usually short time. That's the problem with the pills. They can give you relief, they can get you better, they can get you on either the cell therapy or some trial, but they cannot cure you. And that's the cell therapy. So how does it work? You have tumors, and a surgeon like Dr. Skitsky, will remove one or more of these tumors. We send it actually to the laboratory, and what they will do, they will actually clean up the tumor, the gray ones, from the immune cells, the red, the yellow. See, that's clean up, so they isolate them. It's a mixture, it's a mixed bag. And what they do, they actually now grow them, they actually give them, like nutrition, to multiply them. And this on the right side, if you want it, I don't have time for it, but these are the CAR T cell therapies, which we also try to do, but they are more in the research, that's where you actually manipulate, cells you get actually from the vein. But this is what is approved. This is the TIL cell therapy. And what happens then? So first, you remove the tumor. Then you are making those cells in the laboratory. You admit the patient to the hospital, and you give them some chemo, just basically to make space for those cells, when they come. Now the cells are coming, and you give them, now patient has like a space, to give these cells back, because you cannot give them when there are all the cells, you need to create a little opening, there. And then you give them the interleukin-2, the famous interleukin-2, but not too much, just a little bit to feed those cells, so they can happily grow. And then you have patients recover and go home. It's a one-stop shopping from here to here. It takes about 4 weeks. When you add some lag time, to discuss, wait, and do. And here it's about 6 weeks, time. So ideally, we try to talk to patients who may need this early, because you don't want to lose any time, because still it will take some time. And you can imagine that some patients will have progression before that all is done. And this is a trial, actually, they did in Netherlands, Dr. Hahn, a good friend of mine. And what he did, he took patients who progressed, on on a PD-1, like Keytruda or Opdivo, and he randomized them to either those TILs or to give them the ipilimumab. They didn't get the ipilimumab frontline. So you may ask, what about if they got ipilimumab? They were not on this trial. And the data actually looks good because this is the people who got cells, and this is the people who got ipilimumab, so this is good. But when you look, it's about 5% of patients who were really helped long-term. There are some, here who were helped, kind of middle term. And then there is, of course, half of the patients, will progress pretty quickly, so that's something to have in mind, that the cell therapy, although it's good, it doesn't help everybody. But if you are here, you are a very happy person because you are now 72 months and you should have been dead and you are alive, and everybody's happy here. And that's why we do it. But we want to push this rate, eventually higher, but more work is required. And this is the American study, which we participated in. We simply just took the TILs again, and there was no control arm. Everybody got the cells. And the claim to fame is this, the cryopreserved lifileucel, because while the first ones in the Netherlands, they cannot travel. You have to be in Netherlands and get the cells, freshly made. Here, the process is that you can actually make them anywhere, or make them in a lab in a central, location in Philadelphia. And because you can freeze them, that's what it means. Cryopreserved means they're frozen. You can ship them around the world, on ice, and they can travel. So that's the beauty of that approach. And I will show you what happened here. So these are heavily pretreated patients. They have really no good options left. And about 30% of them have actually response. So they have shrinkage of the tumor, about 6% complete response, 25%, good, 30% plus shrinkage, even 50% some stable disease, so it is a good treatment. However, it can be toxic. And of course, it is to be done in centers which have the teams and support available, because you cannot do it in a regular doctor's office. And when you ask how the durability of response is, so if you think 100%, this is the 30% of patients, and about 10%, 20% will kind of drop down, here. So really, again, when you are thinking about it, these are the patients you really want long-term. It's about 50-50. You are really helping from those patients who got the TILs. If you ask, what about these patients? How many of 100 get in the cells are these long-term, survivors? It's actually about 15 to 20%, so it's not everybody, but it's a real number, and if patient is, able to and interested, then we can do it. And there is a 1 out of 5 chance that they will be alive without progression, 4 or 5 years later, which is a very long time. But some caveats, there was a real risk of dying from the procedure. So we really need planning, multidisciplinary support, and all eligible patients should be considered ideally early, where the performance status is better. And that's the opportunity for collaboration with our community partners, because if you don't come to Roswell and you come, to regular doctor, we need to collaborate, because you can be treated there. You can get your Ipi-Nivo, you can get your Nivorella, but if you need TILs, you need to be here. They cannot do it, even if they want it, they cannot do it, because you have to be certified. And, you can use the targeting of the BRAF mutation as a bridging therapy. And, I didn't speak much about the oncolytic virus, but that can be used, for these progressing patients as well. And we would like to get to individualizing the therapy, because a lot of this is kind of lumping patients together. We are not there yet. The BRAF helps you. Looking at, the immunotoxicity helps you, because you may at least gauge who maybe take the toxicities well if they happen and who doesn't. And like I said, we are working on the biomarkers. And one idea is to use the biomarkers early as you are starting, the ipi-nivo or nivo-rela, and kind of gauge or glean, who may be the early progressor, so you can get ready with your TILs or other clinical trials. And there is a lot on horizon. We have them, all pretty much here. There is a peptide vaccine coming, whether it's positive or negative, we don't know, but we have a global phase 3 trial enrolled, with peptide vaccine. So you hear about vaccines for melanoma. So we'll see. If it's positive, it will be big news. If it's negative, it will be just a dud. But if it's a positive, it will be actually bigger than Moderna. You hear about Moderna, COVID, BioNTech. So we will actually scoop them. So we'll see. Quarter 4 of 2024, we'll have top-line response data. And in quarter 3 or 4 of 2025, we'll have progression-free survival data, which will tell us if it's a positive or negative trial. And if it's positive, then we will obviously have it. And it's a simple vaccine, like you get a vaccine from your diphtheria or, tetanus. It's kind of a similar, simple, vaccine, not sophisticated like these mRNA vaccines. So I like that. But again, we'll see. Then different cytokines, the interleukin-2 you heard about, but there is 12, 18 others. There are agonists to stimulate other parts of the immune system. There are other ways to engage with the tumor. And don't forget, don't ever count, the targeted therapies out, because just because these MEK, targeted therapies so far were kind of beaten, and they are a little limited, it doesn't mean you cannot develop better one and actually kind of get right back, to the fight. And what I really like, there is an antibody which targets melanoma, specifically, like you have seen, and it's called melanocortin receptor, melanocortin, and they put like a piece of radioactive label on it. And it looks like it could be potentially something good for these patients I showed you who die quickly, those 20-30%. So we'll see how that works. But you have to have some patience for that. And I'll thank you. And I thank Dr. Switzer and Aim at Melanoma and our community outreach team for organizing this wonderful, wonderful symposium and open the podium for questions from all the speakers. Thank you.